Kottayam. Today, we are extremely privileged to have two great teachers as our external examiners. Padma Shri Dr. Mohan Kameswaran, Director, Madras India Research Foundation, Chennai, and Dr. Mary Kurian, Head of Department, Pondicherry Institute of Medical Sciences. As internal examiners, we have our very own Dr. Sadruddin Ahmed, Professor and HOD, Government Medical College, Kottayam, and Dr. Shibu George, Professor, Government Medical College, Kottayam. At the outset, I would like to thank Mohan sir and Mary madam for graciously accepting our invitation and taking time out from their busy schedule for enlightening us. Over to you, Shibu sir.
Good evening, everyone. Anjay has already done the honors formal welcome, but I think it is due on my part, at least to extend a warm welcome to Mohan sir and Mary ma'am, and moreover that I have to thank profusely. See, there was this discussion of having external examiners from outside the state. I just thought of having Mohan sir's name, and I was skeptical whether he's going to accept that. And I called Mohan sir without a doubt. Immediately he told, okay, why not? I shall attend. Just ask me the date. And thus we had just a minor adjustment of date just because he was attending some other meeting on that day. That's all. So thank you so much, Mohan sir. It's just from our side. And again, then we wanted to have someone at par with Mohan sir, and we thought of Mary ma'am.
Absolutely no.
Mary ma'am, again, as sweet as she can be, she immediately agreed to come as an external examiner. So thank you so much, Mohan sir. Mary ma'am,
Shibu, thank you very much. But Mary is very sweet, smile, but you don't get carried away whether she can be a tough examiner.
Not really. Come on.
She's a very good examiner. Anyway, it's a privilege to be along with her. Thank you.
So myself and Sadar is really privileged to host you, both of you, sir, sir and madam. And I think our children are really lucky to have you as examiners. Thank you so much. Our presenter is Dr. Arya. Arya, please introduce yourself to Mohan sir and Mary ma'am.
Hello, sir. Good evening, all respected teachers and my dear friends. I am Dr. Arya Jain, third year resident, Government Medical College, Kottayam. Today, I am here to present a clinical case on rhinology, and I am very happy and very thankful for the organizers of this program for giving me this valuable opportunity to present before the dons of ENT fraternity. Thank you.
Go ahead, Arya. I think you can start your presentation.
Yes, yeah.
Arya, you can start your presentation.
Yeah, I think the slides were loaded. We did see them. What happened?
Arya, you are muted. Arya, you're muted. Unmute and then talk.
Arya, you can start your presentation. Okay,
yes.
Right.
My patient is Mr. Suresh, a 51-year-old male patient who is a government employee hailing from Chennai, Alappuzha.
Again muted. Yes, correct.
Presenting complaints, bilateral nasal obstruction and bilateral nasal discharge for past 8 years, decreased sense of smell for past 2 years. Coming to history of present illness, patient was apparently normal 8 years back when he developed left-sided nasal obstruction, which was insidious in onset, was gradually progressive, and it is aggravated on exposure to cold and on lying down. And initially, his symptoms were relieved with the use of steroid nasal sprays. And a few months later, patient developed similar complaints on right side. He used his history of aggravation of symptoms for past 2 years, and now he is having no symptomatic relief even with use of nasal sprays. And his symptoms are persistent throughout the day. He also gives history of nasal discharge for past 8 years, which is mucoid in nature, not foul smelling, not blood stained, and there's no history of any frank bleeding, and also gives history of occasional pulmonary discharge associated with headache and facial pain, which is relieved with oral antibiotics. He also gives history of post-nasal discharge. Patient is having decreased sense of smell for past 2 years, insidious in onset and gradually progressive, and there is no history of other disturbances in smell. There is no history of any visual disturbances, no history of facial swelling or numbness over face, no difficulty in opening mouth or complaints of dental pain or loosening of tooth, no history of vomiting, seizure or personality changes, no history of any voice change, no history of any recent onset snoring, no history of ear block or ear pain or decreased hearing, no history of any neck swelling, no history of loss of weight or loss of appetite. Coming to history of past illness, there is no history of bronchial asthma or drug allergy, no history of diabetes, mellitus, hypertension, or coronary artery disease, no history of tuberculosis or any other chronic pulmonary illness in the past, no history of any nasal surgeries in the past, not on any regular drugs other than nasal sprays. Personal history, patient is following a non-vegetarian diet, sleep and appetite normal, bowel and bladder habits are regular, he is used to social drinking, and no history of smoking. Family history, he is married and has 2 children, no history of malignancies or similar illness in the family. Socioeconomic status, he belongs to a upper middle class family. Coming to general examination, a patient is conscious and oriented.
Arya, before you go to
sir.
general exam, can you summarize the salient features of your history? Give us the salient features of your history.
Sorry. My patient is a 51-year-old male without any comorbidities, presented with a long-standing history of bilateral nasal obstruction and nasal discharge for past 8 years, and decreased sense of smell for past 2 years. Initially, his symptoms was relieved with use of nasal sprays, but for past 2 years, he is having aggravation of symptoms, and there is no symptomatic relief with the use of nasal sprays. And there's no significant past history or history of nasal surgeries.
Okay. One history which you should have, probably need to take also is there any history of drug allergies in this patient?
No, sir. No history of drug allergy.
Okay, which drug am I particularly thinking about, do you think?
Sir, any history of allergy to NSAIDs, particularly aspirin?
Aspirin, yeah. So NSAID sensitivity, right? Now that's important. Particularly, obviously, we presume that you're going to talk about the history of nasal polyps on what you said. So then, in that case, becomes relevant to think about NSAID allergies. What is the association, do you think?
Sir, it is asking exacerbated respiratory disease. It's a triad of symptoms of aspirin sensitivity, bronchial asthma, and nasal polyposis, known as Amtus triad.
Yeah, so obviously that's something that you have to keep in mind, isn't it, when you're taking this? Okay, fine. Go ahead with the examination.
General examination of the patient. Patient is conscious and oriented, moderately built and nourished, voice normal. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pitting pedal edema. Examination of vitals. Patient is subfebril, pulse rate 86 per minute, regular rhythm, volume and character. BP is 110/70 millimeters of mercury in right arm sitting position. Respiratory rate 18 per minute. Coming to ENT examination. Examination of external nasal framework normal. Post-spatular test, nasal airway patency was reduced on left side. Coatis test and modified coatis test were negative bilaterally. Examination of columel and vestibule normal. Anti-rhinoscopy examination. Septum was central. On examination of right nasal cavity, there were multiple pale grayish white glistening smooth surface mass seen filling middle third of right nasal cavity, reaching anteriorly up to 1 centimeter behind anterior end of inferior turbinate and inferiorly stopping just short of floor of nasal cavity. On probing, there were multiple masses, soft in consistency, insensitive to touch, not bleeding on touch, and probe can be passed all around the mass. An examination of left nasal cavity, also there were multiple pale grayish white glistening smooth surface mass seen filling the middle third of right nasal left nasal cavity, reaching anteriorly just short of anterior end of inferior turbinate and inferiorly stopping just short of floor of nasal cavity. On probing, there are multiple masses which are soft in consistency, insensitive to touch, not bleeding on touch, and probe can be passed all around the mass.
What do you mean by probe can be passed all around the mass?
Except cannot be all around.
If it is all around the mass, then it is hanging in the nose, isn't it?
Mm.
So it has to be attached somewhere. You agree with me or no?
Yes, sir.
Yeah, so it has to come from somewhere, right? It can't be hanging inside the middle of the nose. So if your probe is passing all around it, it means it's a sphere sitting in the middle of the nose.
Foreign body, multiple.
She means laterally, sir. Except laterally.
Except laterally, yes.
Except,
That's what you're
yeah,
trying to
there's
say.
no less.
It can be passed all around except laterally, where it's
All
from where it's attached. Isn't it? That's what you're trying to say. Yeah, what you're trying to say is that you can pass your probe between the septum and the polyp and also inferiorly and above it. Yeah. Okay, good.
Go ahead.
So this is the diagnostic nasal endoscopic video of the patient.
Yeah. Where did you tell us what you're seeing as your
Yeah, say as you see. Scope pass to which nasal cavity, what you see.
Yeah, this is the first pass. So what are you doing? So
Sorry, okay, sir, okay.
you want to play again, Arya? You give us a running commentary.
Okay. Okay, sir. Okay. This examination of left nasal cavity. We can see pale polypoidal masses filling middle third of the nasal cavity without touching the floor. And this is the first pass. Examination of nasopharynx. There is no extension of the mass to nasopharynx, and we can see pale polypoidal lesions filling middle third of the nasal cavity, anteriorly extending to just short of anterior end of inferior turbinate, filling the middle meatus.
Do you want to go once again and say, you described only the polyps. Is there anything else that's staring at you?
Yeah.
Go back to, yeah. See, many times you don't see polyps. Something else gives you. Go back to nasopharynx. What else can you see? You can't see the polyp in the nasopharynx, I think. But what else? What can you see? Which gives you an idea what are the sinuses involved. Yes, go back. Yes, describe where do you see?
Ma'am, there is discharge in the.
Come down. I thought, no. In the beginning, I saw now, not very clear. Yes, behind the eustachian tube or in front of the eustachian tube.
Ma'am, and anterior and inferior to eustachian tube.
Then what else? It's very thick, tenacious, isn't it?
Thick mucus.
Yes, very thick, tenacious mucus. Let's describe that, no? And also, I think the medial aspect of one of the polyps is a little more congested. Come back.
That's right.
Yes.
Very
Come back. As you enter, it stares at you. As you come back, I can see that. I think it's very important. Describe each and everything as you see. Huh? Don't underestimate any
very hyperemic. It's very vascular.
No, fairly hyperemic, but very different from the other. Yes, that aspect.
Okay.
Come back to the other side. Go ahead. We just pitched in as and when, don't want to waste time to come back again. That's why.
Posterior endoscopic examination. Posterior end of the nasal septum was normal. Posterior end of bilateral inferior and middle turbinates were normal. Bilateral choana was free. Bilateral eustachian tube orifice and pores of Rosenmuller was normal. Roof and posterior wall of nasopharynx normal. And there was no paranasal sinus tenderness. Examination of face and orbit. There's no proptosis, no ptosis. There's no intraorbital blunting. There's no obliteration of nasofacial groove. Root of nose was normal. Facial sensation was normal bilaterally. Vision and extraocular movements were normal. Corneal and conjunctival reflexes were present bilaterally. Examination of oral cavity and oropharynx. Mouth opening was normal.
നീ കുളിച്ചിട്ടില്ല നീ എനിക്ക് തന്നേ അതിടല്ലേ
Someone's house. Go ahead.
Examination of oral cavity and oropharynx. Mouth opening was normal. Lips, angle of mouth, gingival sulcus, gingival-buccal sulcus, buccal mucosa, gums, teeth, floor of mouth, anterior two-third of the tongue, gingival-lingual sulcus, retromolar tricone area, and head palate normal.
Is
Examination
there
of oropharynx.
anything positive to let us know? I think you should. It's all normal from what you say. Yes.
Normal. Oral cavity, oropharynx, ear and neck examination was within normal.
Here also.
Okay, right. What may you expect in the year, in a case like this?
Here, presence of any TM retraction, serous otitis media, conductive hearing loss.
Absolutely, and you can have CSI because it's long-standing sinonasal polyps, obviously.
Yes,
Right?
polyps.
Okay, right.
Your clinical diagnosis. You are going to say a short findings also, summary of your findings.
Okay, madam. This 51-year-old male without any comorbidities, presented with a long-standing bilateral.
No, you already said the history.
No,
you already go to the findings summary. History is already said. No, don't.
On examination of the nasal cavity, there are multiple pale polypoidal grayish white glistening mass in filling bilateral nasal cavity, predominantly the middle one third, without any extension to the nasopharynx or paranasal sinus tenderness.
So, clinical diagnosis?
Yeah, provisional diagnosis.
Based on history and clinical examination, suggestive of chronic rhinosinusitis with nasal polyposis.
Aryan, can I just interrupt and just comment on your history and examination for in your history? I think you said bilateral nasal obstruction progressively worsening. How was it? Complete, partial? Was it sleep disturbed? You didn't. You need to say it more graphically. You understood, huh? Because it's a sleep disturbed breathing and things like that. Though it's no, you say it for children, but I think for adults also. And then the second part is you did say no frank epistaxis.
Yeah.
To me, a 51-year-old person, even a small epistaxis will change it. So if you use frank, means if suddenly I took it, oh, he might have had small episodes. Was it that or no?
Either minimal bleeding in the patient with nasal mass significant in adult.
Did he have minimal bleeding?
No, ma'am. No, madam. No history of any.
So then you have to categorically say, because he's 51 years old, you see, it makes a world of a difference. And then you went to history, no history of, and you repeated that no history of many times. It's very rude to the ear when you say that. So whenever we club all the negatives together and say, maybe knows things to the night. This is even when you present for examination, it's very important. You club it together. Then going back, what was it? The findings offhand, I think that's all I noted. Few things, it is important. Then general physical, I thought it was, but coming to the nose examination, you said external. Then you went on to say, come to the next one. Yeah. Is it traditional to do the functional test before examination or other ways? Think of ear. How do you do ear? You do the pinna, external, medial, ear, then function test. Then you go to palpation. So this is, you cannot do this. It is important. You understood? You tell the anterior, after vestibule exam, columella, vestibule, anterior rhinoscopy. In fact, you went to endoscopy and posterior rhinoscopy. Is that how you examine a patient? Posterior rhinoscopy. Endoscopy, you have to take the patient to another room, or is it at your bedside? At your side? No. See, I know endoscopy is part of clinical now. Still, I don't think it will come after posterior rhinoscopy. See, posterior rhinoscopy becomes irrelevant if you do endoscopy and then go. So I think these steps has to be very clear. Number two, and anything that these are one. And I think when you describe the lesion, when you said in your summary, you said pale grayish mass or something. I think you must remember it has to be the smooth surface is very important. Smooth surfaced. Because if you have a person, if I say what is surfaced mass, you will have a differential, isn't it? So you must say it is smooth surface. So everything. And I think when you described, you told to us the left side and the right side exactly the same findings, isn't it? Yes or no?
Ma'am, anterior extension is different.
Little
Right,
different.
Little
So,
different.
and for a listening, if we are examining somebody listening, is it good to hear like that, or just say the common things and marginally difference in the size other than that? Isn't it? So, I mean, these are just things that you just have to brush upon as saying. That's all I thought. That's all. Huh? Thanks, sir.
Yeah, Arya, the other thing I wanted to ask was, see, you talked about general examination, right? You started with general exam, and then you came to ENT exam, right? Okay.
Examination.
And then after that, you went to system exam. Now, see, respiratory system in this patient is very important. You have to go a little more detail into this patient. Okay, and the CNS is fine, cardiovascular is fine, but respiratory in a patient with sinonasal polyposis is very, very important. So you have to go a little more detail, because you would expect that, a lot of them would be asthmatics, and vice versa. A lot of asthmatics may come with sinonasal polyposis. So even though the patient may deny a history of asthma, they may still show signs of respiratory signs. So you have to say that there's no, there's vesicular breathing both sides, and both sides lung is good. There's no adventitious sounds, there's no rhonchi, no crepitation. So you have to, go a little more detail into the respiratory system, because in this particular patient, your examiners will look for that, will look for. See, you are going at a postgraduate level. So you are expected to be thinking about all probabilities, all associations, and then ruling them all out. Okay. So you are looking, for even rare, conditions. So, and this is not so rare, having a associated bronchial asthma or something is definitely not rare. Or a patient may be, having bronchiectasis, for example, since childhood, maybe cardiac since childhood. So you have to really start looking at all that, those rare things. You may have those features. Okay, right? Now, if this patient was 50 years old.
So like Mohan said, probably after ear, nose, and throat, you can say a little more on the larynx and chest symptoms as relevant negative, isn't it, Mohan? Yeah.
Yes, absolutely. Yes. I think
Right.
you should emphasize a bit on that, because other things are fine. You say CNS is normal, cardiovascular system is normal, things like that. But the two things that you would be focusing on is the skin, whether there's any skin allergies, any eczema is present. And the other thing is whether there is any respiratory symptoms. So these two things you have to be definitely mentioning in a case of sinonasal polyposis. Okay, you have to look for eczema, look at the target areas. That also you have to exclude in your system examination.
Arya, how did you clinically look for proptosis? as an ENT surgeon. I'm not seeing as an ophthalmologist.
Okay. Ma'am, it should be examiner should stand behind the patient and with neck hyperextended. Look for any protrusion of the eyeball. Look from back after extending the neck of the patient. Look from back. Any protrusion of the eyeball more than the supraorbital margin is considered to be patient's having proptosis.
Yeah, that's generally for an ENT surgeon, we accept, but that is a clinical examination. So your diagnosis is chronic rhinosinusitis with
Nasal polyposis bilateral.
Okay. Now, can you tell me the European position paper definition, 2020 definition?
Yeah.
Just say it, define. What is
as per
chronic?
it was 2020, it is chronic rhinosinusitis in adults is defined as inflammation of nose and paranasal sinuses characterized by any two of the following symptoms. One should be either nasal obstruction or nasal blockage or nasal discharge without facial pain or pressure or loss of smell of decreased smell sensation with the endoscopic or CT with the either endoscopic or CT findings suggestive of chronic rhinosinusitis. Endoscopically, any discharge in the middle meatus or any edema in the middle meatus or polyp or edema in the middle meatus. CT, any findings of opacification of the sinuses. Lasting for a period of more than 12 weeks.
After a latest episode. Now tell me, your patient, if I say clinically put it into a clinical scoring, how much would you give for your patient? Endoscopic scoring? We didn't come to the CT yet.
And endoscopically, we can score using a Lung Kennedy scoring system.
Yes, that is the easiest that we follow.
It is based on presence of polyps, edema, discharge, scarring, or crusting of in the sinuses. This patient.
Simplest is in 1991, so two of them, discharge and polyps or edema. Then the maximum score of 12. I think that is the easiest to remember. Okay. So when you can, this don't need this way beyond, but in an early case. Yeah, go ahead. I'll yes and when.
What is your next step now, Arya? What are you going to do next?
So after this, I have to do all the baseline blood investigation of the patient to know the baseline health status. In addition to that, I will
what
also
are the blood investigations you're going to order?
Routine blood investigations, CBC, CBC, and the lung function.
What is routine for you may not be routine for me. You know, so it's a very yeah.
All the baseline investigation includes complete blood count, blood sugar value, liver function and liver function and kidney function test, then screening. Screening and ECG.
Why liver function test?
Yeah, why all this?
Why are you asking for liver function? You think you're alcoholic?
No, sir. I occasionally take of alcohol. Yes.
Okay. Right. So you're not very happy about the morality of this man. Anyway, you can understand. All right.
So once we are planning for surgery, treatment part, we need all the baseline investigation.
Okay, fine. Well enough.
Arya, you got this diagnosis for this patient, huh? Correct? You can hear me?
Okay, madam, I can hear you.
Yes, you have diagnosed this patient. Now, suppose a patient is sitting in front of you. Tell me how you will advise him. What is patient say, doctor, what do I have? What am I supposed to do? Or what are you going to do to me? Tell me in your words how you will explain to the patient.
Explain to the patient.
Yeah. In his words and your words, it has to be a mix of both. He should understand and you should be clear.
I will
Don't worry, just imagine.
I will explain about the.
No, you explain. I will listen.
Assuming that we are patients.
We are all patients.
Now, and we ask you, so you're a doctor, so tell us now.
So why I'm saying is this is one part I have always seen children come for exam. And just it's a situation.
I will explain to the patient about the disease condition. He's having
Arya, you have to advise him. Okay, advise the
Advice,
patient.
just advise him.
Your
Arya.
mother is asking you
An
to advise the
OPD.
patient.
Yes,
Possibly,
sitting in an OP. Yes.
you're an OP. Don't think that you're addressing the gathering. You address a patient.
Yes, say it.
You are having
What is his name?
Santosh, Madam Santosh.
You must say, Mr. Santosh. In fact, you said male patient. Generally, I feel you should say gentleman or a lady. Don't use male and female. I'm very conscious.
Quite insulting, actually.
Yes, male, and you must say gentleman and a lady. That's the best, or a child.
If you don't like a lady, you say female. Okay. You generally
Even male, generally. So these are small things, but you must have a habit of it. Yeah, you say Mr. Santosh.
So yeah. So yeah.
After seeing you and examining, this is my diagnosis, is a condition. Like that, just say like a story, Arya, or you must learn to say. If you're conscious about it now, doesn't matter, but make it a habit. That is, and these are my plans. And why I should do this, you must say. Because I feel it's a little too big. You already gave medicines. You told us, no? So much is on treatment. Yes, you say it.
Arya, you talk to me. You talk to me. Tell me what I am the patient. Then just tell me. And I'm a difficult patient also. Yeah.
Mohan is listening. Tell.
I'm sitting, and the patient sitting here looking at the doctor. Doctor seems to be nervous looking at the patient. I'm just asking you what you're going to tell.
Mr. Suresh, based on my clinic, based on my assessment, you are having nasal benign condition. You are having a chronic.
What is a layman's term? Polyp, they will all know, which is what? Can't say benign and malignant. Those are big words. Chronic dimple swelling. Yeah, some swelling in your nose. Yeah, that is blocking your airway or your breathing.
Okay, so what? I got polyp, tissue in my nose.
Actually, I will start your medical management.
What does it mean?
We can have it. We can have a trial of medical treatment first. If your symptoms are not improving with this treatment, we have to plan surgery. So I will prescribe you with some.
How long am I going to have this medical management, and why should I have this medical management? What happens if I don't have the medical management?
Initially, I will consider a trial of a steroid, oral systemic steroids and nasal spray for the patient.
My neighbor tells me that steroids is bad for me. Everybody says steroid is bad. You are telling me you're going to give steroids.
As the patient is having no contraindication for systemic steroids, a short course of systemic steroids.
Why do you say he has no contraindication? What are the contraindications?
The patient has no comorbidities like diabetes or hypertension.
Yeah, okay. Hypertension, you saw the BP, no. Diabetes, probably you have to do the blood test. You could have told that, no, why doctor asked, no, Dr. Mohan, why you want to do all these tests? That time, you should say, isn't it? So,
management.
Yeah, see, Maria, you have to talk to the patient in a way that the patient will trust you, isn't it?
Yes.
You yourself sound very doubtful. Patient is going to not have great faith in this doctor. So you have
go to another person.
Right now. The way you're talking to me, I don't think I'm going to change my doctor. That's what my first response is. So you have to be very convincing, and for that you have to be clear about what you're going to say. See, supposing I'm in your shoes, I'll tell the patient, look, Mr. So-and-so, you've been having this nasal blockage for a very long time, I'm afraid. You have allowed your disease to grow, and the result of which is that you've got all the tissues growing inside your nose, is blocking your nose. It's not
Yes.
good for you, because this is, you have to learn to breathe through your nose. And if you can't breathe through your nose, then there are many negative effects to that. So now you are at a situation where you are really completely blocked off. So I have to give you a trial with medicines. Hopefully it will work. If it doesn't work, then you have to go for surgery, I'm afraid. And that is because of this long period that you have allowed your tissue disease to grow. So now medical treatment, I have to put you on steroids. And even though they have side effects, the main effects outweigh the side effects. So the benefits outweigh the side effects. That's why I have to give you the steroids for a short course and see whether it makes a difference. If you are lucky and it works, then you may escape a surgery. If not, you're going to end up in surgery to clear the polyps. So this is a thing, but before I do all that, I have to get some more investigations done for you. I have not done a CT scan for you. I have to do it. I have to run some blood tests, see whether these blood tests are important. You're going to get results to know about your general health. So all this I have to tell the patient. See, the patient has to get a full picture about why you're going to do all this, as Mary was saying, and if you don't do it, what happens? And if you do it, then what are the side effects of what you're giving? And in spite of the side effects, you're still giving it. Why are you giving it? So all this has to be conveyed to the patient, isn't it? So this is why. So don't be. I know you know all this, but
Yes.
but don't be reluctant to part with the information. The patient is entitled to know the information. So you have to be. You have to learn to talk to the patient, communicate with the patient. Very, very essential for a surgeon before you start sharpening your knives, isn't it? Yeah. Okay. So now your diagnosis you're given. Investigations, you told me you're going to do blood tests. So what are the blood tests? You said routine blood tests, hemogram, and all that you're going to be doing. Anything else specifically in this patient?
So in addition to this, serum Ig and absolute eosinophilic count
Serum
validation
Ig.
could also be done.
Serum Ig, is it?
Serum Ig.
All these are going to change your management.
Why serum Ig? I'm glad you said that.
So it's an important
Supposing serum
marker
Ig is very high,
indicated
what does it tell you?
after it indicated it's inflammatory marker.
Yeah. Supposing this patient has got a very high serum Ig, how does it change your management?
Perioperative steroids can be given
Okay,
to
steroids.
reduce inflammation and
Yeah, but that you're going to give anyway, isn't it? Whether serum Ig is high or not, before you take up this patient, you're going to put on steroids, right? But what is what you said is important. What you said is right. But why? I'm asking you why. Why is the serum Ig being high? How does it, impact in the long term? How does it help you?
Sir, in patients with elevated serum Ig, there is increased risk of recurrence of the disease.
Recurrence of the disease, okay. I mean, it's going to recur anyway. We all know that. Ig or no Ig, polyps are going to grow back. Only a question of when. You're not going to promise the patient that I'm going to operate and that's the end of the story, is it? Definitely not going to do that. You're going to tell him you're going to be under follow-up, definitely, and we're going to be keeping you under medication for, in case it recurs. Yeah, but the reason I'm asking you this is, what is the role of, we're getting now new drugs which are, we're starting to use in polyps, isn't it?
Okay, sir.
What are the new drugs which are coming up?
Monoclonal antibodies.
Yeah, the biologicals. Biologicals are now coming in, and high serum Ig would be a very good situation for you to start biologicals in the long term. So that would be a definite indicator. There are very good biologicals which are indicated in high Ig conditions, right? So so those are all things which are now coming up. So that's the reason why when you're doing this test, baseline test, it's important for you to know about how this is going to impact your management and the right.
Yes.
Okay, so blood test. You said you're going to get a CTPNS, right?
Mm.
What are you going to request? CTPNS. You're going to, what is the requisition you're going to write for the radiologist?
Sorry, non-contrast CT nose and paranasal sinuses with appropriate coronal, sagittal, and axial cuts.
Okay, now tell me
Usually
why
take
you
three
want
to
each of these cuts. Why do you want coronal? Why do you want sagittal? Why do you want axial?
Coronal is the best view as far as surgery is concerned. In coronal section, we can view as
So which means you're
Oh.
planning for surgery. So you are doing it pre-operative, or there are other reasons you want to do, or just pre-operative? As a pre-operative mandate.
after medical course of medical management, we can proceed with if you're planning for surgery, we have to proceed with the CT, nose and paranasal sinuses.
Okay.
Okay, that's right.
What is the information you're getting out of it? Tell me. One is coronal view. You said is a good view for the surgeon. I agree with you.
So we will look at the extent of disease involvement. We can score the severity of disease with the CT, and using landmark scoring system, we can score the severity of the disease. We can rule out alternate diagnosis.
Severity of the disease, you already know clinically, isn't it?
Yeah.
Multiple powder filling. Extent probably. Anything else?
What else can you see?
Bone integrity, sir.
Bone integrity.
Whether there is
Okay.
any
Right.
erosion or
Okay,
again,
so you are
anatomy,
saying
Anything else inside the sinus?
Sir.
Anything else?
so normal anatomy and anatomical variations.
See, for you actually.
No, let's say that. Let's say that you have opacity in the sinus. Is there anything you want to look inside the opacity?
Any heterogeneous opacifications to rule out fungal etiology.
What would that tell you?
Heterogeneous opacification indicate hyperdense contents, which is suggestive of fungal etiology. AFR.
Allergic fungal etiology. Okay, right. So that's another thing that information you might get.
See,
Okay.
Aryan, before you do the CT, did you make an attempt to look for a fungal doubtful in your endoscopy, which you didn't say? I was wanted to ask you. Is it important endoscopy? Yeah.
Yes, ma'am. Presence of allergic news in diagnostic endoscopy.
Absolutely.
So you have to say it. It's an 8-year history, not 1 and 2. It's 8-year history. Very important to ask that. And then others also, you must look for it and you must say no evidence. You must say it, because if you see a debris, and what is a debris classically described as? Allergic fungal sinusitis. Mucin, if you see.
Allergic mucin is a peanut butter appearance or axil base appearance.
Oh, axil is very good.
Right.
So something like that, yeah.
If you see that under the microscope, what will you have?
Any presence of fungal hyphae, eosinophils.
Fungal hyphae, how do you see? Depends on your stain. Tell me the stain. Where will you see hyphae? KOH stain, what will you see? Hematoxyl eosinophil stain, what will you see? KOH may be difficult.
GM stain or
that is that is the specific stain. What do you see in an allergic fungal? No, the Mohinas, in that classical HNE stain picture.
Charcoal laden crystals.
Yeah, good.
Fungal hyphae.
What are charcoal laden crystals?
What are they made of?
Eosinophilic
And how does the eosinophilic material vacuolated, and how does the fungus come being seen in a hematox HNE stain? It's actually vacuolated emptiness in a layer of eosinophilic color. So how do you see it in GMS stain? Fungus, how is it stained? What is the picture of the fungus in a GMS stain?
Hyphae of the fungus can be seen.
What color is the stain? Doesn't matter. Go back and look because it's very important. The
Yeah.
KOH stain. And what is the commonest fungus anyhow? If this person had fungus, like
What would you expect? Yes.
Most common fungus causing AFR is Dematicious fungi, Alternaria, Carularia, Papillarius, etc. The common
are they the common in the nose? Dematicious is
No.
the one for this patient? Like Mohan said, you find heterogeneous opacity. So which fungus is quite possible?
Aspergillus fumigatus.
So what is the KOH stain pattern?
Septate Aspergillus septate hyphae.
Yeah. So the Chinese letter.
Septate hyphae, yeah, angled branching septate hyphae. In
Chinese
fact,
letter, yeah. Right. So, okay. So you have this stain, and you can see that in the CT. Coming back to your CT, your axial coronal view. You ask for also axial view. Why do you want axial view?
Axial view, the frontal orbital apex optic nerve. If there is onodi cell, this all can be well visualized in axial.
why do you want to
also
see all
frontal
this? Why are you looking for optic cells or nodal cell? Why are you looking for all this? Before you
once we are planning for surgery, to avoid complications, anatomy should
why
be
do you
well
want
known
the
to the surgeon.
complications for these? Tell the clue word. These you are looking for high risk areas of anatomical, normal anatomical variations that can be a high risk. That is the entire exercise. For your particular patient, you are not doing heterogeneous opacity and all. I don't know because you didn't say it. So when the question asks you, try to point. I want to see this. So what are the high risk areas?
High risk areas, we have to depth of olfactory fossa should be assessed based on Cross classification. Type 3 Cross classification is increased risk of injury if it is a type 3 Cross of
Tell me how the olfactory fossa, you're worried about the olfactory fossa. Tell me how the olfactory fossa is formed. Tell me the boundaries of the olfactory fossa.
Depth of olfactory is determined with the length of lateral lamella of the cribriform plate.
Length of the lateral lamella. Okay, and its connection
lateral
at
lamella, horizontal lamella, lateral lamella, and cristagalliform.
So which is a medial boundary? You have said it. Which is a medial boundary?
Medial boundary is cristagalli, lateral lamella, and the floor is formed by.
What is the superior limit of the fossa?
Superior limit.
Olfactory fossa. How do you calculate the depth? That will tell you the superior limit. Lateral lamella getting attached to what?
The foveate modalis, roof of the foveate modalis.
No, what do you mean by foveate modalis? What is the roof? Roof is actually the frontal bone, the thick frontal bone connecting with the lateral lamella, which is the thinnest. So superior most boundary is that level. Why is that a high risk area? Which part of the roof is most dangerous?
The junction between modalis and lateral lamella.
Why?
Lateral lamella and foveate modalis.
Why?
It's the junction of thick bone and thin bone.
Tell me the measurement of the thick
artery. It is the
measurement of the thick and thin. Thick and thin.
Foveate modalis is a thick bone and lateral lamella is a thin bone. And at the junction of these two bones, anterior artery pierces.
Yeah, so it's also perforated by a vessel.
Yeah, thick and thin bone is 0.5 mm and 0.05.
0.05 mm.
It is that is the difference.
Okay, right. And
then
so what are the other risk areas?
Yes. So you looked at fovea. Okay, you looked at the roof.
Any dehiscence of lamina patricia.
Right.
Only dehiscence or anything else?
Medially.
Medialized lamina patricia. When does that occur? When does lamina papyracea come closer? When maxillary sinus is hypoplastic.
Hypoplastic.
Permeabilization or any injury. Okay, you finish lamina. Then?
Any carotid canal deficiency or sphenoid intersphenoid septum, presence of dehiscence of carotid canal, presence of abnormal luminization of the ethmoid like Haller cell, Onodi cell.
Okay. What is Onodi cell?
Onodi cell, sometimes the posterior ethmoid may luminize posteriorly in the sphenoid bone, forming a supralateral cell known as Onodi cell. In such situation, the optic nerve will be in relation to the Onodi, the posterior ethmoid rather than with the sphenoid sinus.
Okay.
Okay.
Good.
How do you identify Onodi cell?
Yeah.
In a coronal CT, any cell above the air cell above posterior corona is sphenoid. If there is a cell above that, or it can be well visualized in axial CT relation.
Yeah, actually
Axial
coronal and axial, but you start visualizing in the coronal, it is in the posterior and lateral. That is the word, posterior lateral. What will happen when there is an Onodi?
Chance of optic, we should be.
Yeah, what happens is the optic nerve, I mean, even sometimes the carotid canal wall will be doing so. So there's Onodi, you finish.
There's important structures like the optic nerve.
Then what else? Something else more important you didn't say. It's good to say it along with the olfactory fossa. Sometimes when we do a fess, in the habit of removing it just gets injured. What is it? Other high risk areas. Other high risk areas.
For the artery, whether it is liminal or
Mary madam, you are muted, madam.
Oh, I didn't mute.
Yeah. So you talked about the risk areas in your CT. Now there's one more question I have about CT, and that is you asked for a sagittal view. Why? What are you getting information in the sagittal view?
Sagittal view about the frontal sinus drainage pathway, the frontal recess area, and pneumatization of sphenoid pneumatization. Type of sphenoid pneumatization can.
Yeah.
So this
no.
also.
I was telling about anterior ethmoidal artery, which I think we make it a habit to see, very important. And which view do you see and how do you identify it?
Anterior artery, then at the in coronal
yes.
view,
If,
level of skin.
No, as the notch occurs, it pulls, you can see it at the level of the notch.
Yeah.
So what is the difference?
Yeah.
And an extension like. So it could be where and it could be where. One is high risk and one is relatively safe.
There is a supra. If the bulla pneumatization, if there is a suprabullar recess, chance of artery being in a mesentery and passing through the ethmoid.
Yes, it is a high risk.
The suprabullar recess is very high.
Yes, so that is also there. So you have covered most of the. So yes, do you know a mnemonic which will help you to remember? Because it is important that you make a habit to see. And actually in the night before rounds, my residents have to fill up the CT finding of this mnemonic. Have you heard of the mnemonic? Aryan? No, it's actually, I also was quite upset that I read it very late. The article came way back in 2016. It's called CLOSE, C-L-O-S-E. That is close is cribriform plate, L is lamina papyracea, O is Onodi cell, S is sphenoid, and E is anterior ethmoidal artery. And I will share the article because I read it about 1-2 years ago, which I felt bad. I read it very late, but it does. then it very helps. In fact, in lamina papyracea, we can extract a little more about maxillary sinus hypoplasia into that, because it comes to that. It's a very interesting, it's called close. And I think in the West, then I asked in the West, they said they follow it very routinely pre-op. Because many other articles which taught us to read were so exhaustive, we get very tired. It's so cumbersome that we don't apply it. This is the least, so we can work on it. That's it.
And I have one last question for you. I think we're running out of time. You mentioned briefly about the biologicals. Do you know which biologicals are now
As
approved
only
in sinonasal polyps? Which are the ones which are officially now approved and available? Sinonasal polyps. What are the drugs?
others are
Sir, there are mainly omalizumab, which is the anti-IG antibody, and mepolizumab. Then
Mepolizumab.
in post 2020, anti-IgG antibody, dupilumab is.
Dupilumab is the only one which is FDA approved, I think. The other one is still
Now,
in
right
trial.
now, I think dupilumab also is approved.
Yeah, dupilumab is the only one FDA approved, I
And
think.
omalizumab also has been approved. So
Approved now.
so these two I know for sure. Mepolizumab, I don't know. I mean, I think it is also in the final phase. Maybe it's approved
I
now.
think they are. I think in UK they are doing it.
Fine. So
Fine.
anyway, these two are definitely available now. And what are the indications for biologicals? When would you give biologicals? You need to check that out. Check that out, because this is something which is very recent. They can ask you in your recent advances also. So look that up. What are the indications now? What are the current biologicals which are being approved? Mechanism of action, and how effective they are. So all this you need to be knowing. Not, of course, in a case like this will be discussed, but also you could be asked in recent advances, right?
Okay.
Aryan, suppose a patient came with, you want to do a CT scan. You did one 6 months ago or 9 months ago. Patient came a little late. He decided to come again. You're planning to do surgery. Is it good to repeat CT of the paranasal sinuses unless there is an absolute indication? What is the time factor which is radiologically we are able to do routine para repeat? It's about 6 months. Yeah, that's because we have multi-slice ones and our lens are exposed 218 times more. Do you know any other CT scan which is now come that is reduced 70 to 80 points? In fact, it's come, it's become very good. But many centers do not have it. Very good. So that is another thing that is coming more and more. So you're planning to operate, no? You said? Yes. And you told them you're going to operate. Mohan wants to ask any steps on the operation. How is she going to prepare?
I think we'll ask. Shibu,
Sir,
how much time do we have? I think we already asked.
No, sir, you have time, sir. 7 to 9.
It's 1 more hour, Mohan.
Okay.
I
thought we were already exhausted and enough.
No, I think. Are you exhausted, Arya?
No, ma'am, no.
Oh, come on.
Quite resilient, I must say.
Yeah.
I think if you are going to tell us about surgery, you should start with the preoperative workup. That's what we would like to know. How would you prepare this patient? Let's say that you have decided, you've tried medical management, not very effectively, and so you have talked to the patient, and the patient also has agreed that now I want relief. So let us think about surgery. So preoperatively, what are you going to counsel the patient? How are you going to, what are the things you're going to do for the patient?
Preoperatively, we have to do all the investigation as already mentioned, radiological and blood investigations. now we have to get a written informed consent after explaining the complications and risk of surgery and need for post follow-up. Then we can give a short course of, if there is extensive disease and extensive disease, we can give a short course of steroids. And if there are any signs of infection, a course of antibiotics can also be given preoperatively.
Why, Arya? Why do you want to give the steroids and preoperative antibiotics? What's the advantage of it?
Because it reduces the inflammation and reduces the bleeding during surgery,
Okay.
and better surgical field and less complications.
Good. Yeah. Okay. So you're going to give the steroids. What steroids do you prefer?
Prednisolone 0.5 to 1 mg per kg
Yeah.
is given
And how many days do you give
over a
before
course of 7 to 10 days.
surgery? 10
Preoperatively,
days. Okay, fine. Okay.
7 to 10 days.
Right. Fair enough. Yeah. So you want to give it and then take up the patient to surgery. Anything else preoperatively you want to give or tell the patient? What are you going to tell him about the surgery? How are you going to counsel them about surgery?
All the complications of the surgery and
Not complications
we
first.
should
What
get a written
tell-
informed consent about.
So what are you going to tell them? Sorry, straight away, if you
Tell
tell me I'm going to cause complications for you, I'll run away.
Run away. Till when the operation.
So what are you going to tell me? Why, first let me assume that I'm the patient sitting in front of you. And
So
you're
then,
telling me you're going to do surgery.
need for surgery. First, we have to explain the need for surgery, sir. How it is going to improve the symptoms and improve its quality of life.
I'm the patient. I'm sitting in front of you.
We are planning.
Arya, you have already told all that. He has decided for surgery. You have done investigation. He's telling you tomorrow or going for surgery. Isn't that
What
you
are you
want?
going to tell me?
That's what he wants.
We are planning. We are
Already
planning for
planned.
a endoscopic guided surgery. We have planned a endoscopic guided surgery under general anesthesia for you. And
Very technical words, Arya. So you tell him, sir, tomorrow we'll take you to theater, but we will give you medicine, you will sleep, you will be comfortable. You won't know what is being done.
Arya, you can do that in Malayalam if you want.
Tell in Malayalam also.
I think we can both understand.
Yes, I know.
So
Tell.
that will be better for you as well.
See, what is important is patient is very worried, and we all know during surgery you won't know, but you will many times you may need to pack the nose. There are surgeons who don't pack. So that must be shared with the patient.
See, Arya, if you're going for your national board exam,
exactly.
you have one station only for
No, even theory-wise, there is this time's theory in Tamil Nadu was consenting for a mastoid or consenting for some surgery. The consent process,
So you have to talk to the patient. You have to learn to talk to the patient. You cannot sit there and, be looking at the patient and the patient looking at you both, it doesn't really get on anywhere. So you have to learn to communicate. Very important, because you suddenly freeze up. And the moment you say, talk to me, you freeze up and you start sort of fidgeting. That doesn't help. You have to talk to the patient. You ask Shibu or, they will tell you, because at the end of the day, it's all about communication. Telling them about what you're going to do. So I'm here, I'm the patient, I'm sitting in front of you, and you are looking at me. So I'm looking at you with a lot of respect and hope.
Hope, yeah, it's a hope.
So what are you going to tell me now? And also anxiety, because I don't know what's going to come tomorrow. So tell me.
We are planning for a surgery for you tomorrow. Tomorrow morning we will be taking you to the theater, and surgery will be done after sedating you with the medications. So you won't be knowing the pain or.
Will there be pain, madam?
All that you have to say is, no, we will give medicine for pain. You won't know. Something like that.
Yeah. So you're going to give me anesthesia. Are you going to give me anesthesia?
Yes, yes, sir. We will be giving anesthesia for you, and it's done with endoscopy. No incisions will be put on the face, or we are using endoscope and doing the surgery. And post surgery, after surgery, some pack will be kept in your nose, and it will be removed on the next post-operative day only. It will cause some discomfort, but will be removed.
Okay. When you say it will cause discomfort, isn't it? Would you like to give him an alternative thing for to reduce his discomfort? What will you do? Tell him. But you can breathe through your mouth.
You
It's a
want
little
possible breathe through your mouth?
You can breathe through your mouth. You know, you must give him some support. You just say discomfort and then say, oh, then what will I do? Patient is all. So gentle words to overcome also must be said in the same tone. Mohan is not convinced. Some more you want, Mohan?
I'm just thinking about what the patient will be thinking, you know. Yeah, so okay, so you're trying to convince me. I'm still not very convinced about this whole thing, you know. But basically, yes, okay, we agree for surgery. You're telling me you're going to give me anesthesia, so I won't remember anything. And then you're going to do with endoscope inside my nose. You're going to do operation. Then what I want to know is it safe operation? Is it safe or is it dangerous? Is there any danger in the operation that I should know about?
Like any other surgery, every surgery has got complications, and
that's not very encouraging, is it? See, you can. What you have to say is it's a safe operation. First thing you have to say is it is a safe operation, right? Because we don't start up by saying, you know, every surgery has got complications. So, you know, then the sure way of putting the patient off. So you just tell him that, first of all, it is a safe operation. The vast majority of the patients is very safe and it works very well and they get well and they go home without any issues. Occasionally, the complications may happen, but that's very, very rare. And then you tell them, you know, if they ask you what are the complications, then you can say, but don't start up by saying, surgery, you know, like any surgery, you will also have complications, and that's not very encouraging to the patient. So your first statement must be that you are a safe surgeon, and the surgery is a safe surgery. This is the first statement that you make. And then, of course, you know, if they ask you, go on asking you, you know, tell me what are the possible complications, then you tell them possible complications. But again, reinforce and say that these are all very, very rare. You know, it's not something which happens frequently, very rare. In fact, what I tell my patients is, it's like, you know, you get into the flight, the air hostess tells you that if you have a water landing, you have to do this. If your plane and oxygen pressure drops, you have your mask and so on. It doesn't mean it's going to happen, you know, but she still tells us. So that's the kind of thing, you know, it's a very, very rare possibility, but it's my duty to inform you. So I'm telling you, but you don't have to get worried about it because these are all extremely rare. Yeah. So you have to reassure the patient.
Also, it will be useful to tell, as I said, we will always take care that it does not happen at any time. We feel it is not safe, we will stop and we will come back to it. But also, if you tell, it is quite assuring to the patient. You know, sometimes it can bleed and your vision may not conducive for your continuing surgery. So we will come back. We may have to take you again. So that is also a lot of confidence for the patient, you know. So that also will be important. I don't know. This is all things that...
Yeah, that's right. That's exactly right. And then the long-term outcome also, that also you have to tell them. See, the patient may like to know that after the operation, will I be cured 100%? It's a common question they'll ask you. Will I be cured 100%, doctor? Will you guarantee that I'm going to be perfectly fine after the surgery? What will you say?
No, it is not complete with surgery. A post-op follow-up and post-op medical treatment is we have to continue intranasal steroids and with nasal diffusion sprays post-operatively, and regular follow-up is important. There is high chance of recurrence of the disease.
Yeah, that's right. You have to say that this is a disease which has by nature a very high possibility of recurrence. But we can minimize the recurrence by good follow-up and by post-operatively keeping you on medicines. You don't have to tell them what medicines you're going to get.
Yeah,
You tell them, I'm going to keep you on medicines and follow up and keep a close watch on you. And with that,
exactly.
we minimize the risk of recurrence. But if you don't do that, then you will have recurrence. So it's important to follow up even after the surgery. Surgery is not the end all. It is the beginning of a long follow-up. So you have to have the follow-up is as important as the surgery. Isn't it? That's what you're going to tell the patient. Right.
And you can also tell the patient it's the treatment for this, particularly this illness, is evolving. We may get better medicines.
Better
We will
medicine.
be, yes, and which will postpone the recurrences or keep it under control, and so somehow encourage the patient so he knows.
What is the current limiting factor for biologicals? What do you think? Why are we not giving biologicals to everybody with polyps?
The cost of treatment.
Cost, yeah, that's it.
Oh,
So this
very expensive.
so you're not going to be jumping and giving it to everyone, isn't it? So it's only for the patient who say comes with multiple surgeries, who's having really has had 12 operations, 13 operations, and you do an endoscopic surgery and 2 months later he comes back with polyps. That's the kind of patient you will be seriously considering it. Otherwise, it's a very, very expensive proposition at the moment. This is why you don't do it very often. Then supposing you're taking up the patient for surgery, and now in the surgery, during the surgery, like Mary is saying, the patient has bleeding. Okay. Now, what are the possible sites of hemorrhage from this patient with endoscopic surgery, during endoscopic surgery? And what are the possible sites that you can expect bleeding?
Yes, expect, yes.
If there is a increased inflammation, the patient can have diffuse hemorrhage.
Yeah.
And specific
Correct.
bleeding, once we are bleeding from the, once we are budding the middle meatal androstomy posteriorly, can injure the sphenopalatine artery, branches sphenopalatine artery, and can bleed.
Good.
Then, while working at the bulla region and widening frontal recess, can cause injury to anterior mode artery and result in anterior mode artery bleeding. Then, in the sphenoethmoid angle region,
Correct.
posterior artery is in the 5 millimeter anterior to sphenoethmoid angle.
So tell me, how do you manage each one of them? How do you manage? I want to know how you would manage an anterior-ethmoidal bleed, how you would manage a sphenoethmoidal artery bleed, and a posterior-ethmoidal artery bleed.
It can be managed with the anterior artery bleeding. If there is injury to anterior artery, there is high chance of retraction of the artery in the orbit and can result in orbital hematoma.
It may retract, it may not retract. So supposing you are intraoperatively you see bleeding. I'm not talking about post-operative. Supposing intraoperatively there is a bleed, and you find out that anterior is bleeding. Okay, then what do you do about it? How do you manage it?
We can cautery, CC bipolar cautery.
Bipolar cautery, okay.
Yeah. No,
That's the
that's
simplest thing, yes. Fine. So that will sort out the bleeding. It's a very simple artery. It's a teeny weeny artery. It's not a great big artery. We worry about it only because of the potential that it may, like you said, it may retract to the orbit and cause an orbital hematoma. Otherwise, it's no great significance. It's not, nobody's going to die of exsanguination from the anterior artery. So that's not a problem. But the only problem is the risk to the orbit, right?
orbit, correct.
So intraoperatively, you cauterize. Fine. Now, post-operatively, if it bleeds, how do you pick it up? How do you diagnose it? Let's say intraoperatively, you're not picked it up, but post-operatively in the ward, there is a hemorrhage from the anterior artery. What will be the presentation?
Sir, can you repeat the question once again?
No. Intraoperatively, you're not particularly diagnosed an anterioethmoidal bleed, but postoperatively, suppose there's an anterioethmoidal bleeding happening in the ward, what would be the presentation of the patient? How would the patient present?
Presentation with the patient will present with the eye pain, eye symptoms, protrusion of the eyeball, difficulty in eye movements, and it will deteriorate the vision.
So, okay, so how are you going to manage this patient? Supposing they call you from the ward.
First, we have to immediately remove the nasal packs.
Okay, good.
After that, start on IV steroids.
Okay.
Can we start on IV mannitol and acetazolamide, and with the monitoring of vision, and we have to send the emergency ophthalmology consultation, and we have to monitor the vision of ocular movements, presence of RFPD, and the intraocular pressure should be measured with the.
So what is normally done?
If there's no improvement with this medical management, we can proceed with the lateral canthotomy and cantholasis. And even if there's no improvement with that, we have to go for endoscopic medial orbital wall decompression.
Absolutely. Yeah.
Correct.
So the sooner you take the patient and decompress, the better. If there's a growing hematoma, isn't it?
It's a hematoma. Arya, this normally when you finish scopy, when you finish the FES, what is the first checkup that you do in the recovery? It's mandatory, just like post-mastoid patient wakes up. There are a few mandatory. You check on the table.
We have to examine the extraocular movement. We have to examine the extraocular movements. Look for ask for any history of diplopia, vision and reflex of vision and pupillary.
So actually, you look for proptosis that time also on the bed. You look, and another thing one tends to forget, you have to look at the cornea.
Corneal
aberrations is something people tend to miss out. Because it should not be the next day the eye is red and you call the ophthalmologist. So certain mandatory checkups on the table and before the patient leaves the recovery room.
Right.
What else?
So anterioethmoidal bleeding, you told me. Then what happened to sphenopalatine bleeding? How do you manage that?
Sphenopalatine bleeding, saying we can use cautery, and there are sphenopalatine clipping can be done.
Usually stops with cautery, bipolar cautery.
Yes, clipping is not, because by the time you have done some, there's another area which tends to bleed, not intra-op. Actually, generally it is at the end of the surgery when the surgeon is trying to make everything right and everything clear. There's one area which will bleed if we are not aware of it. And actually some of them do a cautery mandatory before, which is that area. You know, the middle turbinate, some of them, sometimes to avoid lateralization, they tend to excise part of it and the stump always. Yes. And then it bleeds not on table the next day. So it is important to, if you work to do anything on the middle turbinate, you must cauterize it, preemptively cauterize it. Then what else? Maxillary sinus ostium. What is important when you make the ostium wide and why? Aryan, can you hear? You have an accessory ostium and.
Please, we can. We have to look, ma'am, I didn't get the question, ma'am. Can you please repeat?
No, maxillary sinus ostium when you widen. What are the two, at least minimum, a few principles that you incorporate while doing it in that?
After ancillary, we can visualize nasal ostium. If it is patent, there is no need for further manipulation. And if there is an axillary ostium, we have to widen the axillary ostium and nasal ostium together. It should be joined with
incorporate it.
In the nasal.
Another thing what you should avoid is making an annular raw area. one tends to do an anterior removal and then posterior. It should not be done actually. You go more inferior than anterior. How much anterior can you come? What happens if you make you do with the backbiting, you open anteriorly? What can get injured?
Nasolacrimal duct. Nasolacrimal duct locating.
Duct will get injured.
Nasolacrimal duct.
What is the most difficult area? And I know your area to operate on, and even many of the rhinologists say do not do unless it's necessary, which is
Frontal.
yeah. In fact, yes, frontal sinus surgery is the most challenging and which can land into problem unless it's necessary. Do not. Anything else? What is
Mary Madam, Mohan sir just left. He'll come back just in 5 minutes. There's some emergency here. Patient.
okay?
Surgical emergency, something. He'll come back in 5 minutes. Just told me.
Surgical.
Some
He's on
patients
call.
have undergone surgery has come back. He'll come back immediately.
No problem. She is answering well. See, the thing is that sometimes this counseling things are sometimes we are not doing enough in our children, youngsters, isn't it? Counseling questions. You can't hear me? Yeah. Yeah, you're all right. Done? Emergency is over?
No, madam. He'll just come back in 5 minutes. That's what he told.
Oh, Mohan, huh? Okay.
Yeah, Mohan sir.
No, Aryan, please don't get upset because we are asking on this counseling questions and how you advise, because it must come naturally to you when you become a consultant. It must come naturally to you. That is the reason we are trying to ask questions on that. Huh?
Mary Madam, there are other examiners in the audience. Can we get their comments in?
Please. I thought there weren't any. I just wait for people to say. Please go ahead.
Routinely done. That's routinely done. That's right.
Please.
It's a long history, you said like 8 years. Because it is a short history. What are the special diagnosis and possibilities?
Short history. Sir, if your patient is presenting with a short history, you have to rule out malignant conditions.
Short history. No epistaxis, isn't it, sir? You wanted no epistaxis?
Yes, epistaxis come. High disturbance also there. The short history like less than 15 minutes going for like that. So what are specific things you should look for eye examination in the face?
I can't hear you, sir.
Suppose it is a short history less than 6 months. Then involving the patient presenting. Then what all things you specifically?
Sir, audio is breaking. I can't hear you properly.
You mean it's a same age, 51-year-old with a short history? Is that what you wanted?
Yes, madam.
Short history, nasal obstruction, eye symptoms also, sir?
Yes, madam.
Arya, with eye symptoms as well.
Eye symptoms and bilateral nasal obstruction, we have to rule out sinus malignancies, ma'am.
Short history, he said 2 weeks, no? Was it 2 weeks?
Maybe months, less than.
Ma'am,
Less than a month.
Ma'am, any complication of the sinusitis? Infection spreading into the orbit.
What complication? 51-year-old. I don't know. I don't know what sir has in mind. Yes. Somebody else has said. Somebody else has said on the screen. Somebody else is told on the screen. You can say.
Invasive fungal sinusitis.
I think so. 51-year-old, short history, 1 month. He said eye symptoms. Is that what you're thinking, sir?
Definitely, more than that, malignancy also has to be considered.
Yeah. But you said not blood stain, no? That's what I thought. Anyhow. Suppose you are thinking more malignancy. In terms of malignancy. Arya, what will you look in the CT? And what investigation will you order and what will you look in that?
You have to look for any bone erosions.
Yes.
Of the sinuses.
Yes. Once you see the bone erosion, what will you look for? What will you ask for?
An extension of the orbit or intracranial, any orbital
What
or
other investigation will you ask for?
We have to MRI, madam. MRI nose and paralysis sinus with the brain and organ.
What MRI?
MRI, nose and paralysis sinuses.
What
Contrast
MRI?
enhanced MRI, madam. Contrast enhanced MRI.
Dural and intraocular involvement, what does MRI show? What are the features in MRI that you have a suspicious? If you don't know, that's fine. You can go and read up because it's more of a malignant. You can say that, especially in the orbit. That's okay. You know what happens is it's called straddling of the fat, and fat, there's a tumor normal tissue interface. There will be nodularity, and in the muscles there will be extra thickening of the muscles. Isn't it, Shibu? These are few things that we look for.
Yes, madam.
Yeah, so you have to look for it actually. Even the dura will also show it. But then they say inflammatory malignancy, there will be a difference, but that's when they do a diffusion. Cellular and water diffusion differences they look for. That's a recent one, diffuse plate imaging in MRI, isn't it? So these are things it's good to know step by step.
Arya, suppose this is a unilateral nasal mass and you take an MRI. What specifically will you look for in an MRI? Unilateral mass. It looks like a polyp, but you are not very sure.
The surface can be warty, correct?
Convoluted cerebriform pattern.
So what do you mean by that?
What is that
Look
called?
for any convoluted cerebriform pattern, alternate hypo and hypodense areas which is seen in inverted papilloma due to specific histopathology.
Okay.
Yeah, that is correct. And what is the radiological feature in a fungal sinusitis sometimes labeled as? It's a radiological term for it.
Double density.
I know, there's a term sometimes they use. Dash sky.
Starry sky appearance. Starry sky appearance.
Now, what is the reason they have this density? You didn't mention it actually.
Because of it is iron and manganese crystals.
Manganese of the dead fungus, which will show. What will happen classically, fungal reaction? What will happen to the walls of the sinuses?
Any expansion of osteoitis at all?
Usually they say the walls are very thickened. Of course, in allergic fungal, they can remodel, and thickening is another feature that you look for.
What is the classification of sinusitis? Latest classification, Arya.
Latest classification of it was classification.
Yeah.
It was
Just give an outline.
Classified as primary and classified as primary and secondary rhinosinusitis. Then primary is further classified as a diffuse or localized based on unilateral or bilateral involvement. Then based on the endotype, it is divided as type 2 or non-type 2. And again classified and secondary is also classified as diffuse and localized, and further based on whether it is immune mediated mechanical obstruction.
So based on the latest classification, what is your diagnosis in this case?
Chronic rhinosinusitis, primary diffuse. As chronic rhinosinusitis, primary diffuse, non-type 2 CRS with an process.
Okay.
I wanted to ask something else. You finish your short. What is the role for using navigation? What is your intraoperative navigation system? Is it mandatory? Is it important? What is the present accepted indications? I know there was a time every center was ordering for it and doing it.
Investigative surgeries are used in skull-based surgeries and revision cases.
Yes, now the American Academy has come with revision. What else?
Spinal hypophyseectomies.
They say usually revisions, and there is an developmental abnormality. And then, of course, endoscope, CSF, intracranial endoscopic CSF repair. And it is not advisable for the routine cases now. That is the present American Academy of Otolaryngology's advice. What do you say, Shibu? He's not listening.
I'm muted, madam. I'm muted. I was muted. That's why. Yeah, agree, madam. Agree with you.
Yes, so that is one thing. It's coming a very, very important discussions are happening. But there are too many uses of it. Now, if you see septations in the sphenoid sinus operatively, intraoperatively, what are the don'ts? Can you say at least theoretically?
Sometimes this intrasphenoid septum it will divide sphenoid asymmetrically, and it will be attached to the lateral wall into the carotid canal.
Yes. Optic. So it's best not to remove septations unless when you widen the sphenoid sinus ostium, how do you widen it? Is there don'ts to that too? Just like the widening of the maxillary sinus?
And there are various approaches. We can approach medial by
no, sphenoid sinus, not no, when you widen the sphenoid sinus ostium.
When approaching via efforts, we have to approach intramedially to avoid injury to skull base and lamina patricia.
No, what is the approach is called? Okay, I'll come back. What are the approaches to?
Never approach supralaterally. We can Sphenoid approaches can be classified as lateral approach, that is a trans-ethmoid approach, or medial approach, or an intermediate approach. Middle approaches can be approached via the natural sphenoid ostium and it is widened. Trans-ethmoid, a artificial opening is created, and while widening never goes supralaterally. You have to widen it inframedially.
Yeah. There was, it was earlier called as techniques. I don't know whether they still follow it. Do you know what the techniques were earlier of surgeons of yesteryears? Not transepted, both the anterior approach and posterior approach. Posterior to anterior and anterior to posterior. You have labeled it, but
Mr. King, Weigand approach.
Weigand approach and
Posterior to anterior approach is known as Weigand approach, and there is Messerkinger or Stamberger approach.
No, it's not Stamberger, it's Messerkinger only. Stamberger is a student. Which do you follow? Which does your Shibu follow? These days they say it's a mix of both, isn't it?
പറയാൻ പേടിയാ madam, അതുകൊണ്ട് പറയാത്തതാ.
No, it's technically allowed also, mix of both. That is what the, I mean, I also do a mix of both. It's difficult to note. What is a Haddad's flap?
Haddad's flap
You talked about bleeding. What are the
Haddad's flap is posterior nasal posterior nasal artery based flap based on posterior septal artery. It's a branch sphenopalatine. Posterior septal artery based flap.
Usually when you raise it, normally when do you use these flaps that much? At least racing and all is for a higher person.
Yes.
Huh? For? Usually it's for transsphenoidal surgeries, or a widened, extended skull-based surgeries you tend to use. And Haddad has one more name to it, no? Some Basovka, something. I can't pronounce the name at all. Yes. Yeah, Basovastagi. One is Italian, not Italian. Usually it has
reduce bleeding. What are the measures to reduce bleeding? You already talked about bleeding. What are the measures to reduce bleeding during endoscopic sinus?
Start from the symbol.
First, pre-op steroids and pre-op antibiotics to reduce inflammation and thus reducing the bleeding.
Do you normally routinely do it in your center? Do you routinely do it in your center?
No, pre-op antibiotics are not routine. In case of extensive disease, pre-op steroids are given. Patients with elevated IG and antibiotics if there is any symptoms or signs of infection.
Okay, then.
And then pre-op nasal packing prior to surgery. 20 minutes prior to surgery, cotton pledges softening adrenaline.
How much saline, how much adrenaline? Tell all that.
1,000 adrenaline is mixed with here we mix 27 ml of 4% lignocaine with 3 ampules of 1 in 1,000 adrenaline to make it a concentration 1 in 10,000, and it's
3 ampules of
cotton pledges is 3 ampules of 1 in 1,000 adrenaline. 3 ml, 3 ampules of adrenaline. What's the 20?
1 ampule anesthetists allow you to use 30 ml, 3 ampules. Huh? They allow. Huh?
27 ml. 1 in 1,000 adrenaline and 4% lignocaine is used. 3 ampules of 1 in 1,000 adrenaline is mixed with 27 ml of lignocaine.
27 ml of lignocaine. Huh?
Where are you packing or infiltration?
Ada.
Area.
Nasal pack. Ma'am, this was nasal packing. Not locking.
27 ml of lignocaine. Huh?
One ampule is 30 ml, 3 ml is removed and we add 3 ampules of 1000 adrenaline, let's say.
Or is it saline that you use? What do you use there? I'm surprised. Hmm. Okay, other than that, what is the other thing that you use to reduce bleeding?
And surgery can be performed preferably under
Hypotensive. Anything else before that? What is the position of the patient, Arya, when you operate? You may make the position flat or?
I think we lost her. No, yeah, Arya. You're muted. Arya, you're muted.
What is the position of the patient?
Position of the patient. Patient is positioned in reverse Trendelenburg position with a 50 to 30 degree head and elevation.
How much? 30, yeah?
15 to 30 degree. 15
You
degree,
put
10 to
15 to
15 degree head and elevation. No,
10
ma'am,
to
10 to
15
15 degree head and
30
elevation.
will head and elevation. Then you do packing, weight, then?
And anesthesia, preferably hypotensive anesthesia.
Do you routinely ask for hypertension in your center,
No,
Dr.
ma'am.
Shibu?
No, ma'am. No, ma'am. No.
Because we also don't ask now.
I think she was answering the question how to reduce bleeding. Is it?
Yeah.
Is it, Arya? Okay.
Yeah.
How do you achieve hypotensive anesthesia, Arya?
Aim of hypertensive anesthesia is to maintain the mean arterial pressure to 30% of the baseline.
But how do you, what are the
Maintain
drugs which
around
are
60 millimeters of mercury.
What are the drugs used? Actually, hypertensive anesthesia is one question. In
what are the drugs that you use for achieving hypotensive anesthesia? Or what is the drug that the anesthetists use? Let me put it that way.
So,
Okay, you have to read that up, huh? Because as one of the questions which is asked, as a surgeon, you have to know everything about the anesthesia also, right? You have to know about it. So you have to read up about that, huh? It's important. What is the, in fact, hypotensive anesthesia used to be a full question actually. You have to read up all about it, huh?
It still is. Local anesthesia, hypertensive anesthesia are two important anesthesia. She spoke about flats and anything else.
What are the complications you have covered? You have talked about hemorrhage. What are the other complications?
could you please repeat other complications?
Yeah.
Complications are postoperative and intraoperative complications and postoperative complications. About diffuse hemorrhage and arterial injury, we already discussed. Other orbital complications include other orbital complications are any orbital periorbital fat exposure, orbital hematoma, any injury to the extraocular muscles, optic nerve injury, and intracranial complications of CSF rhinorrhea, carotid artery injury.
Okay. Let me ask you another question. Let me ask you another difficult question. You're answering very well, so you can time to go into a little tougher question. Now, let's say you're doing on a patient who has been operated 4 times before. You're the 5th time. You're the 5th surgeon. Okay, so practically all the landmarks are gone. The patient has only got polyps everywhere. There are no landmarks. So now you have to operate again. So what are the landmarks that you will, rely on now in this situation where, there's no middle turbinate, there is no inferior turbinate, is practically not seen. Everywhere you see polyps. So what are the landmarks that you can rely on in a revision phase? In other words, what are the constant landmarks? Huh?
So if no landmarks are present, we can consider Weigand technique, posterior to anterior approach.
Okay, good, very good. So then what are the landmarks you're looking for?
The
Starting,
landmark the surgeon would not have touched.
starting from the choana, right? That is there. You cannot
That is
do
on the
anything.
choana, sphenoid osteum will be present 1.5 centimeter above the choana.
Yeah.
First widen the sphenoid osteum,
Good.
then come anteriorly, posterior ethmoid.
Yeah. So you can see
Maybe the
the
posterior
skull
ethmoid.
base there. You pick up the skull base there also, right? The roof of the sphenoid, you see the cella, and then in front of it, you start seeing the base of the skull, right? Right. Then you come more anteriorly, you see the posterior ethmoid, and
Posterior
roof
ethmoid.
of the posterior ethmoid.
Then anterior ethmoids.
Hmm.
Fuller,
Actually, roof of the
After
maxillary
that,
sinus.
About the orbit, what would be your landmark for it?
one is roof of the roof of the maxillary sinus is the landmark.
Very good. Yeah.
Operating in two stages.
Roof of the maxillary sinus.
Roof of the maxillary sinus. Yeah, that becomes the landmark that you another landmark which is reliable. So these are the landmarks that you would be able to rely upon when you have no other landmarks, isn't it? So, as you said, vegan technique coming from posterior trachea may become an important option then in a very difficult situation. Good, excellent, right. So coming back to your complications, you talked about the risk of injury to all the vital structures, right? Carotid, optic nerve, and so on.
Yes, septations, she said, how to avoid all that, she said. We had asked when you were out there. Yeah.
Yeah, very good. All that is excellent. So, fine. And then what happens? Postoperatively, what are the complications that you can expect?
Postoperatively, any bleeding, postoperative bleeding, sinusitis, any sinus formation.
What are the possible sites of postoperative bleeding?
I didn't get you.
Possible sites of postoperative bleeding, hemorrhage.
Postoperative bleeding. Any mucosal affiliate, middle turbinate.
Middle turbinate, like Dr. Mary said, the patient, one of the common sites is somebody who's partially cut the middle turbinate, then that's a very, very, very common site of secondary hemorrhage. Yes. What else?
Spinopalatine.
Spinopalatine, yes.
It's also
very common site, yes. These are the most common. You're right. Okay. You don't very often see anterioethmoidal, posterior-ethmoidal bleeding. So these are the most common sites. Okay. Supposing you have a very bad sphenopalatine bleed, okay, which doesn't stop by cautery and this and that. You do back, go back, and then again it bleeds. What is the next step that you do when you can't control a sphenopalatine bleed?
We can call it endoscopic sphenopalatine artery ligation as well.
Ligation of sphenopalatine artery, or even more proximally, even may go to the maxillary artery.
maxillary.
Maxillary artery.
Yeah. Where do you find the maxillary artery?
Internal maxillary artery in the turcopalatine fossa.
Very good. Excellent. Fine. So how do you approach it?
Turcopalatine fossa can be approached after through the posterior wall of the maxillary sinus.
Posterior wall of the maxilla, yeah, absolutely. That's right. So it's a very straight on, direct approach. But that's very rare. I mean, you don't have to do it very more often than not. You may be able to just control the sphenopalatine itself. We can actually dissect out a little bit of artery, see that, and then you can clip it or cauterize it, whatever. Okay, fine. So these are the. But then, what are the other postoperative complications? When you're talking about hemorrhage, that's one thing. Any other common? What is the most common postoperative complication?
Most common epiphora. Epiphora.
Synechia is very, very common. We see it all the time.
It's very common.
Very common. So what do you do about it? First of all, should you do something? When should you do something about it?
If it is obstructing the osteomeatal area.
If it is obstructing either the osteomeatal unit or the nasal airway,
Yes.
Nasal passage. Otherwise, you don't have to be worrying about every small little sinus because very often they're not as part of the healing process, isn't it? So if it is blocking either the sinus drainage pathway or the
Pathway.
nasal airway pathway, then only you have to interfere. So how do you deal with it?
That's technical as vulgarization, in which we medialize the middle turbinate. Or
deal with it means to avoid it. Or
Avoid it, yeah.
avoid.
avoid. It will we can resect the synechia and use a nasal spray for a period of 1 week or 10 days.
Okay.
And
You can divide it and keep a sprint there. But even to prevent formation, how do you, during surgery, what are the steps that we take to prevent formation of sinus?
It's gone, huh? I think it's past time, I think, Mohan.
Okay, right.
Ma'am, we have to avoid any raw areas, contact between raw areas.
Yeah. Prevent contact between raw areas. Yes, that's right. And also post-operatively, regular
nasal douching
and cleaning and all that. That's all. Fine, you did that.
She's answered more. Also, sometimes you should not overdo or excise too much of the middle turbinate. That becomes, it will automatically lateralize. So these are few things that as and when you do, you have to be conscious about.
Good. Oh, you did very well, Arya. You did very well.
Yes.
I think you definitely pass. If I was examiner, I would definitely ask you. There's no doubt about it because you are a fountain of knowledge. You have a lot of information.
Shibu, good to you. You're a student.
Yeah.
Certain things we just things that sometimes, which I have also noticed, youngsters. We in our country we do not. Communication is something.
Yeah, that's the only thing. I think you have to, work on your communication skills because you are reluctant to part with information and you're shy. That doesn't help. Surgeons don't become shy people. Surgeons have to be very extrovertish. Talking a lot and explaining everything. So there's no point in trying to be shy. You have to say
it will come with practice. It will come with awareness. I think it just needs to.
See, examination, remember, you are marked for what you're saying, not for what you know. Because the examiner does not know what you know. Examiner only listens to what you're saying. So maybe to literally keep talking all the time. Very
what did
she couldn't imagine you as a patient, sir. That's why.
Sorry?
She couldn't imagine you as a patient, sir. That's possibly that's the reason.
Imagine me as a patient. Well, you'd be surprised who won't come and land upon your clinic. So you have to talk. You have to talk and say, sir, this is it. This is a problem. This is it. Which you're doing every day. You're doing every day in your clinic anyway. You are talking to the patient every day.
Yeah, and another thing I must tell young surgeons is when you go to the theater, if it is one patient which you or you're more familiar, pull down your mask and say hello to the patient. Say, I am here. So these are small things which we tend to forget. And identify yourself in the theater with the patient. Patient becomes very much confident to go through. So I keep telling these small things to youngsters.
Very good. But you did very well. You answered all the questions. You're very fluent in your presentation. There was literally almost no flaw in your presentation.
Yes, absolutely. And all the just the polishing, I just try to tell you. That's all.
Yeah, there were no major flaws. You're all quite nice and smooth, and your presentation was very good. So, I would definitely pass you because from your presentation, it's very clear that you know the subject, you know you have the knowledge required. So all that is fine. But I think you can, you want to be a distinction student. You want to be a distinction student, not just passing. So to be a distinction student, you have to stand apart from the others. So how do you stand apart from the others? It is by communication skills. You have to talk. You have to explain to them. And in fact, in many countries, let me give you an example. So supposing you are in going for an exam in Britain, or you're going for an exam in the US, the American board, or any of these exams, it's not even, you don't even have to know a lot to pass it. You just have to have the gift of the gab. You just have to learn to talk. And very many exams you can just walk through by just talking and you're going through. Many candidates who pass don't know half of what you know.
Yeah, actually,
But they
Mohan,
know how to talk.
they call it working knowledge.
Yes, exactly. Exactly.
So
So
it's working
learn
knowledge.
that ability. So in your everyday presentation,
Yes.
every day, when you talk to the patient, you assume that you're in an exam and you talk to the patient. And how are you talking? And this you have to reproduce in exam. So part of counseling process is also the exam, isn't it? So, when you're doing that in the patient, when you talk to the patient, imagine that this is happening in an exam. What are you talking? And same thing you talk in the exam also. That's the only thing. Otherwise, I don't think there's any flaw in it. You did very well.
Very
Thank you, sir.
Good marks.
so. All the best, Aryan. Keep it
Best
up.
wishes. Yes.
Thank you, sir. Thank you, madam.
Thank you, sir. Thank you, madam.
Oh,
sir.
thanks for calling me.
Anurag, just wind up.
Yes, sir. Yes, sir. Sir, other examiners, do we need to ask them for any?
Yeah, yes.
Yes, please. Yes, please. I'm so sorry.
Already we
Huh?
checked, sir.
One person asked the other person.
Dr. Shibu. Hello. I am Dr. Venugopal, Trivandrum Medical College. It's a nice presentation. It is a nice presentation and also nice discussion. Everything they covered. So nothing else to ask. Thank you.
Other examiners, I mean other examiners in the audience.
Shibu.
Yeah, Sadish, yeah, please.
Satish, yes.
Hello, sir and madam. Good evening.
Hello.
Nice to see
How
you.
are you, madam? How are you, sir?
Nice to hear your voice.
Yeah. So I wanted to add one or two small points. Number one, she should present the history little bit. She was very fast, so it is very difficult to catch up with the history. So she should emphasize which all points are relevant rather than rushing through the history.
Yeah.
Number two, she was telling the symptoms and dividing the history of presenting complaints. Nasal obstruction. Actually, the patient is suffering, and it should be something like a story. It started with this, and he developed a nasal block or nasal discharge, whatever it is. Instead of telling, I am talking about his nasal obstruction. Then, after finishing that, now about nasal discharge. That she should improve by telling as a chronological order what the patient had. Then already sir told about the probe passed all around. Then for improvement, actually I was surprised. Sir and madam told you have passed easily, but your aim should be to go to a distinction.
Yeah.
For that, even in the system examination, sir emphasized to concentrate on the breath sounds, adventitious sounds, etc. Similarly, you know everything, but it is your duty to impress the examiner that you know everything. For that, you should have told cardiovascular system, apex beat felt in the left side. So they know you know about cardiogenic syndrome. Like that, you should modify. Then in the surgery and counseling session itself, you should improve so much. Counseling was not up to the mark. She knows everything, being in government medical college, especially at Kottayam, but it should be a little more impressive. Sir, what you told is absolutely right. When you are talking to the patient, see, tomorrow I am going to operate. These are the complications that will occur. Patient will run away. You will have to tell in a very impressive way, I am going to do a surgery, and you will be anesthetized, and the surgery, there will not be any scars outside. Most probably it will be 100% endoscopic, and you won't know anything, no pain, nothing. and you may be kept in ICU sometimes, and sometimes you will be in the ward. And to prevent bleeding, there may be a pack, so you'll have to breathe through the mouth. Like that, whatever she does every day, she'll have to tell in simple language. And again, emphasis, 100% emphasis should be given to surgery is not the final thing. Surgery is done to remove your disease and to relieve your symptoms and to open up the sinuses, and future medications will reach all these areas. That is the most important thing you will have to convey. And the importance of regular follow-up and the use of medications almost lifelong. That should be emphasized. Then the role of in the history again, I'm telling one or two simple points. You showed us the endoscopic picture, but little bit contradictory. No history of snoring. Yeah, you must have asked the patient whether you are snoring or not. No patient will tell I snore. So you'll have to ask the spouse. Number two, you should, you told voice change. You may be right. I'm telling just be cautious. This much polyp may cause rhinolalia clausa. So you are telling straight away no voice change. You may be 100% right. I am telling in the future, when you tell, you must be cautious. You should look and tell. Then to reduce the bleeding, all majority of us will start beta blocker prior to surgery. So that should be emphasized. Short course of steroid and macrolide antibiotics in the medical management. And one point was never stressed by Arya, the role of saline nasal douche, even before surgery. So douche, steroid, macrolide antibiotics, and even in the endoscopic picture, I saw some purulent discharge, especially posterior part, and some amount of, because of the postnasal discharge, some nasopharyngitis, congestion of the nasopharynx. So all the examiners, both the examiners emphasize there can be allergic fungal rhinosinusitis. For that, you should have told the nature of the nasal discharge. If it is there, it is very difficult to blow out. And so these are my suggestions. I have a long list I have written, but I am not boring you. So you have presented very well. Discussion was also good. From what you told, we know that you know things, but you should improve yourself in answering in a better way to get distinction marks. All the best.
Thank you, sir.
Yeah. I think everybody said the same thing again and again to you. Your communication, if it can be better, you can definitely aim for much better marks. So that's the only thing. Work on it. It's not a problem. Not all of us are born communicators. All of us have worked on it. So we were all at some stage. We were like you, very scared. I can still remember as a postgraduate. First year MSFI and second year MS, how nervous we used to be when we used to see examiners. So it's very normal. But ultimately you realize that examiners also are human beings like you. They are not people with horns. So you have to learn to talk. Very important. And so you talk, the better it is for you, because you impress people. And as I keep telling again and again, candidates, it's very difficult for an examiner to fail a candidate who is smiling at you pleasantly. So don't go in frowning at examiners.
Yeah.
Enemies, go there with a pleasant smile, and automatically that will give you 50% marks. Then after that, you can aim for the rest of the marks. Okay, so go with a pleasant demeanor, the examiners, and talk to them. So don't go there as if you're going for a boxing match when you go for a viva. But you did. That's the take-home method. I don't want you to anyway feel that you have not done well. You've done very well. It's just that they're giving you suggestions to see how you can get better than what you're doing. Okay.
Ari, as for me, I fully agree, but I want to differ a little bit. I want you to learn and be a good doctor and in the bargain get a distinction. But let not study for a distinction. I tell all my youngsters that you do well, you will get distinction your whole life. Let it not be a one-time distinction. That is what I tell my youngsters. What to do. I mean, you will all understand as you grow older. You know, it is very important. Patients are patients, and they are patients. They are not a mode mean for anything. That is it. You study well, you do well, and I'm sure you'll get a distinction. But let not that be the primary aim of making your use of your patients. You know, patients, you will learn from them. They are our lifeline. To tell you the truth, if we look back, all that we are because of our patients.
Sadar sir.
Huh?
Sadar sir.
That's it. Thank you very much for giving me this opportunity. Shibu and Dr. Mohan, as usual, we enjoyed. Few people I did see. Thank you very much.
Sadar?
We have covered almost all things, but instrument side, powered instrument, endoscopes, all these details also has to be, I think we will discuss in further classes actually. What are the endoscopes used, powered instruments, then what are the instruments, concepts and all. Thank you for the, thank you Mohan sir and madam, thank you.
Thank you both. Thank you, Shibu. Thank you,
Thank you, sir.
Both,
Thank you, Mohan,
both.
sir. Thank you, madam. Sadish, thank you. Thank you so much.
Thank you for a
All of
very,
you.
very
Yeah,
Good
very
night.
nice.
Good night.
Venu,
Thank you
Venu,
for the
special
For a small vote of
thanks because I
thanks.
saw Mary after a long time. So thank you.
No, we did meet for the South
We
Pole.
did, but it's quite some time now.
Shall I
We
tell a
did
small
meet.
vote of thanks, sir?
Yeah, Anurag.
So we have come to the end of another session of Fluent. We were extremely fortunate to have Mohan sir and Mary madam as our examiners today. Thank you, sir and madam, for taking the time out and giving 2 precious hours of yours for enhancing our knowledge. Special thanks to Sadruddin sir and Shibu sir for being the internal examiners and making invaluable contributions in the discussion. I would like to congratulate Dr. Arya Jayan for an excellent presentation and for managing to hold her own in front of such legends. A big thanks to all who are logged in today to participate in this event. Your participation is the success of this program. Last but not the least, I would like to thank the Solaris division of Sun Pharma for providing the platform and the necessary technical support. We'll have the next session very soon. See you all then. Thank you and good night.
Okay, thank you. Thank you, sir. Thank you, ma'am.
Bye.